Hello everyone, welcome to our presentation. Our topic is about antibodies and antibody drug conjugates, or ADCS. First of all, we are Group 1 and here's our team. In the main outline, we have the introduction of our topic, the concepts of how they act in the body, and finally, the example of antibody drug conjugates. So firstly, I will talk about the introduction. A challenge of cancer treatment is doing our best to ensure that the benefits of medicines bring outweigh the burden of unwanted side effects. Take chemotherapy, for example. It is a powerful treatment which kills cancer cells, but in doing so, it does not differentiate between the cancer cells and healthy ones. So, it damages healthy cells too, leading to side effects like hair loss and tightness. Monoclonal antibodies are used to treat cancer and are capable of a more target attacks on tumor cells. But what if we could combine the targeting power of monoclonal antibodies and the toxic properties of chemotherapy, ensuring that chemotherapy selectively kills cancer cells? That's where antibody drug conjugates, or ADCS, come in. There are three parts of ADCS. First, a monoclonal antibody that targets or specific proteins on the surface of cancer cells. Second, a potent chemotherapy drug. And finally, linker molecules that attack the chemotherapy drugs skillfully to their antibody, working only when the chemotherapy is inside cancer cells. So, ADCS are designed to specifically strike out cancer cells and deliver their chemotherapy payload directly into these cells, limit damage to healthy ones. For patients, it potentially means fewer unwanted side effects commonly associated with chemotherapy, but all the cancer-killing power. Next, I will continue with Part 2, Concepts. The first concepts are antibodies, antigens, and monoclonal antibodies, which everybody is familiar with, though the course of immunology with Dr. Levando, so we should skip them.
I next present the antibody drug conjugates, ADCS, and here is its structure. In order to achieve the function, ADCS are constructed based on three parts. Antibody, which is humanized or fully human, helps the drug to possess high cancer cell specificity. The second part is linker, which is cleavable or non-cleavable, joins antibody and drug. It conjugates the antibody at the conjugation site by lysine coupling, cysteine alkylation, or enzymatic reaction. Last but not least is cytotoxic drug. It destroys cancer cells, and it has high potency, low immunogenicity, and low cytotoxicity to off-target cells. Next is mechanism of action. This is a figure to illustrate pharmacodynamics of an ADC named SGN35. Here we have HRS, Hodgkin, and Reed-Steinberg cells, which are tumor cells of Hodgkin's lymphoma. The ADC will bind to the antigen on CD30, which is membrane protein of the tumor necrosis factor receptor or tumor marker. The complex internalized through endocytosis mediated by cadherin. A cadherin-coated vesicle containing SGN35 is formed within the cytoplasm, where it is uncoated. The uncoated vesicle infused with lysosome and MMAE, which is a cytotoxic drug, is released after cleavage of the dipeptide linker by cathepsin lysosomal protein. Free MMAE inhibits tubulin polymerization and hence G2M cell cycle arrest and apoptotic cell death. The last part I will present is pharmacokinetics. ADCS are administered through parenteral routes in order to reach systemic circulation. Due to the size and polarity, the distribution of ADCS generally restricted to the vascular and interstitial space. Regardless in the similarity in absorption, distribution, metabolism, and elimination process are regulated differently between ADCS and small molecular drugs. As you can see in the figure, with left side presenting the SM drugs and ADCS for the right side. Briefly, the SM drugs typically undergo metabolism, phase 1 and phase 2, then they are eliminated by the renal routes or biliary routes. In consequence, metabolites are perhaps excreted more easily from the body due to the alternation in polarity, molecular weight, and activity. On the other hand, it is more complex for ADCS, still undergo metabolism in renal routes, since there are non-specific and specific clearances, as can be seen in the blue graphs of the figure. Proteolytic is the only non-specific mechanism. It happens in variety of tissues, including the skin, muscle, and liver, due to macrophage uptake. Antibodies are taken through non-specific pinocytosis and are degraded via lysosomal proteolysis. For specific clearances, target-mediated are the most basic concept. Target-mediated clearance occurs when the antibody binds to the target cell and is internalized and degraded. FcR-mediated is regulated by the binding of antibodies towards Fc gamma receptors expressed on the cell of the mononuclear phagocyte system (MPS). It subsequently leads to internalization and catabolism of MABs. To further increase the efficiency of the FcR-mediated clearance, immunogenicity-mediated was invented by neutralizing and clearing the interleukin-6 that is able to evade clearance due to weak Fc gamma R interaction by a bispecific antibody. The clearance is therefore rapid and efficient.
Challenges are in the formulation considerations, namely the antigen, antibody, linker, and the cytotoxic drug. The target antigen should be highly expressed in tumor cells, but not so in normal cells. The target antigen should also be highly conserved through cell heterogeneity to be effective against as much cancer cells as possible. Monoclonal antibody selection. There are many types of antibody to choose from, such as other than IgG, or whether in full form or fragments for low immunogenicity. The chosen antibody should have high specificity and affinity, and should retain standalone functions such as immune activation, even when paired to drug molecules. Linker selection is also important, as drug release from antibody due to linker instability can determine specificity and off-target effect, especially if the payload drug is super cytotoxic. Finally, the specificity of antibody allows for the use of super toxic agents with less worrying about harming healthy tissues, which requires compatibility with linkers. The development of these wonderful drugs features the same techniques as any other drug, namely the bioanalytical chemistry methods for characterization and screening of drugs.
So, trastuzumab emtansine, which trade name is Casila, is one of the examples for the antibody-drug conjugate. This drug has been used since 2013 to treat patients with HER2-positive metastatic breast cancer, in which HER2 is epidermal growth factor receptor 2. This is the structure of the drug. The right side is the methansine, which is active compound, and the left side is the monoclonal antibody. The antibody and methansine will connect with each other by one non-cleavable linker, which called succinylene transformylamidine cyclohexane 1-carboxylate, or MCC. The succinylene group reacts with amino group in lysine residue of antibody molecule to form the covalent bond. In HER2 breast cancer, at the normal breast cancer cell, the normal amount of HER2 receptor will send signal telling the cells to grow and divide. However, too many HER2 make the cell grow too quickly and so cause cancer. In this trastuzumab mechanism of action, by attached with HER2 receptor, this complex is then internalized into the cells, where the antibody is degraded by protease, which is lysosome, and releasing the active compound metabolized into the cytoplasm. Here, in the cytoplasm, active compound will bind to the microtubule, which involve in cells movement, cells mitosis, and inhibit the microtubule polymerization. In addition to ability of the drug, which is delivered to the tumor cells, trastuzumab also retains the ability to inhibit the HER2-mediated signal transduction and activate the antibody-dependent cell-mediated cytotoxicity. So finally, I want to say that the antibody-drug conjugation is the future potential drug that's needed for many cancer therapy.
So thank you for your attention, and if you have any question, please feel free to ask us.